I'd like to welcome you all to our 37th podcast with me, Michael Edelstein. I'm a clinical psychologist, and Tommy Bateman, who is also a counselor in Virginia. And once again, we're honored to have as our special guest, Dr. David Burns, who's known far and wide among the therapy community. We've been discussing Dr. Burns's team therapy. In previous podcasts, we went over T, testing, E, empathy, and now we're up to A, agenda setting. So Dr. Burns, would you give us a little background on agenda setting, and then Tommy and I will chime in.
Yeah, that sounds fine. A lot of therapists think they know what agenda setting is. Beck had that as a part of cognitive therapy, but what we're talking about in paradoxical agenda setting is nothing at all similar to what most therapists understand or do. When I was first learning cognitive therapy, I was and still am tremendously excited about it, and also REBT as well. And I remember once a psychologist at Penn in some seminar or something asking the question, cognition is fine, but doesn't motivation play a role? What if some people want to be depressed? And I just kind of scoffed at it and thought, what a fool he is. It's all cognition, and just dismissed the concept of resistance and motivation as playing much of a role in therapy. I thought kind of like you guys think, if the patient is there and they're paying for sessions, they must want to get better. And then later on, when I began to notice in the research that REBT and cognitive therapy and every form of psychotherapy was actually falling far short of what we initially expected, and a good half of patients don't respond to any form of psychotherapy or drugs either. So I began doing research on how does psychotherapy work? What are the effective ingredients regardless of the school of therapy? And I tested a lot of things that just didn't pan out at all. And then what jumped out as having a massive causal effect on outcome was motivation. Homework compliance, and I began to rethink the whole issue of motivation, and developed a new way of classifying resistance, thinking about resistance, and have developed maybe 15 or more pretty powerful ways of melting away therapeutic resistance pretty quickly with most patients, and this has absolutely revolutionized our outcomes. I think that the motivation revolution is going to be at least as big as the cognitive revolution that was launched by our beloved Albert Ellis, and also to a certain extent by Aaron Beck and others as well. That's just kind of a brief overview.
Now, I think you described two different types of resistance, right? So what resistance are we working on here? The resistance to the outcome or resistance to the process to begin with, or both?
Oh, great. Yeah, they're both super important. I think cognitive therapists and REBT therapists have vaguely grasped the concept of process resistance. In other words, what process is the patient going to have to engage in to get well, the process that they won't want to engage in. And that's for depression would be doing your psychotherapy homework. For anxiety would be using exposure to confront your fear. For relationship problems, it would be focusing on changing yourself rather than blaming other people and trying to change other people. And for habits and addictions, it would be giving up a tremendous source of pleasure and trading it in for discipline and deprivation. And most patients don't want to engage in those processes, the very processes that they're going to have to engage in to get better. Outcome resistance is a little different and probably more sophisticated and harder for people to understand. And that's the idea that the patient may not even want a good outcome, or let's say is very ambivalent about a good outcome, like the depressed patient. Beck said hopelessness is the worst emotion of all, and almost all depressed patients are hopeless. You'd think depressed patients, oh, they definitely want to recover, but it turns out that most depressed patients have one foot on the shore and one foot in the water. They kind of want to get better, but there are tons of reasons for them to kind of cling to the depression, and they're not the reasons that psychologists and psychiatrists have traditionally focused on. Outcome resistance for anxiety disorders would be that the patient with OCD or panic attacks or the fear of flying or intense shyness, all things, kinds of things that I've had tons of them. The idea is if you press this magic button, your anxiety will disappear. And it turns out that there's intense resistance of anxious patients to recovery. And the key to it is magical thinking, that the anxious patient, on the one hand, they're suffering, but on the other hand, they think, wow, if I get well, something horrible is going to happen. And so that's the dimension of outcome resistance for anxiety. For relationship problems, the outcome resistance is that, a good outcome would be maybe getting close to the person you're pissed off at, that you're not getting along with, your spouse, your brother, your colleague, whoever it is. And then outcome resistance means you don't want to press that magic button. If pressing the magic button means getting close to that person, that you actually don't, part of you, and maybe most of you, doesn't really want to get close to that person. You just want to complain about that person. And then for a habit and addiction, the outcome resistance is giving up what may seem like your only source of pleasure. Getting drunk at night is, it's not a problem, it's my solution. Or overeating is something I love doing. And so what we've done is developed, many techniques to bring the outcome and process resistance to conscious awareness and then melt it away before using any methods. And you asked me, Tommy, last time to give 45 or 20-second responses, so I violated the rule. So I'll kind of shut up now and try to give short responses.
Yeah.
Yeah, well, we're all imperfect humans with imperfect brains,
Yes.
so certainly understandable. I never thought I dealt with resistance, but as you're talking, David, I realize in some way maybe I do. And here are the two ways that I think I do, and I'm not sure if this is what you would refer to as resistance. But I noticed years ago when I was doing RABT in the early years and also training therapists, not only was there, quote, resistance from clients, but also from therapists. From clients in terms of writing out the 3-minute exercises on a regular basis. That's the A, B, C, D, E, F.
Right.
And by resistance, what I mean, they just didn't do it as much as I thought would be useful, and they weren't getting better. And then among therapists that I was training, they were reluctant to emphasize this with their clients because they were afraid it would seem too much like school. That you do your homework and then I'll check on it next time and see how you did it. So the way I think I avoid that now is in the first session, I emphasize a number of times how important it is for them to do the writing out and do the exercises. And I give examples. If you're going to learn a language, would you learn it if you just came to me to teach you French? Or would you learn it if you practice French every day between the sessions, etc.? And what did you change in your life? And didn't it take practice and doing it again and again as you improve? So I make a big case for that. And I don't find much so-called resistance these days. Clients are doing the 3-minute exercises. They bring it in, they show it to me, we go over it, etc. And then I'm not sure if this is resistance, but it's in terms of secondary disturbance. What happens is, particularly with depressed people, deeply depressed people, and they've been going for therapy, it hasn't helped. And what I discover is often there's a secondary disturbance. I must not be depressed. It's awful, I'm depressed. I couldn't stand being depressed for the rest of my life. So they're depressed about being depressed. So that's what's slowing them down. So I focus on the secondary, on the must about not being depressed. And to some extent, I use one of your techniques that I read about where there are advantages to being depressed as well as disadvantages. It's not the end of the world, etc. So that's my experience with resistance.
Well, we're kind of on the same page. There's a massively more than what you described, but as far as what you described, we're all together on that. That was what first got me into the whole issue of motivation and resistance. I did a study in Philadelphia of variables that might predict outcome. And the only thing that had a huge causal effect on outcome was homework compliance. And once we saw that, and I think it's the only thing still in the world literature, that and a motivational scale I developed that predicts homework compliance as well as recovery, are the only variables in the world literature that have ever been shown to have a causal effect on depression, as far as I know. And so that's like the process resistance issue for depression. That's 1/8 of the whole landscape of resistance. But I went even further, and I developed something that's in my therapist toolkit called the concept of self-help memo, and I mailed it to every patient before the first session, and they have to fill it out before they're even allowed to meet me. And then I would go over that on the first session, and it's called the concept of self-help, and it explains that there's a lot of ways to get over depression, but talking and having someone support you, that can help. Some people believe an antidepressant can help, but this clinic emphasizes, in addition to other things, self-help tools. And I mentioned what some of them are, the kinds of things you'll have to do for homework. And then there's a little kind of a contract. I understand that this clinic emphasizes the self-help and homework as a major aspect of the treatment. And then yes, no, or needs discussion. And then the number of minutes per day I agreed to do is, and they have to fill it in. The number of days per week I agreed to do it is they have to fill it in. The number of weeks I agree to continue, and they have to fill it in. And then it lists 25 good in capital letters reasons, not in capital letters and italics, not to do the psychotherapy homework. And then it lists the 25 best reasons that clients gave me over the years why they can't do homework or they shouldn't have to do homework. I feel like a drug should cure me. I think I have a chemical imbalance in my brain, or the homework is too much like being in school, like what you said, or I'm not motivated. I have to be motivated, and they tick off the ones that describe them. And then I negotiate this with them at the initial evaluation, and I say, "Gosh, Martha, it looks like the way you fill this out, it looks like you'd rather not have to do homework." And the patient would say, "Oh, Dr. Burns, I know I've had 12 therapists and none of them asked me to do homework, but there's one kind of homework that helps." "Well, what's that, Martha?" "Oh, well, I like to call my therapist at 3 in the morning if I'm anxious, and that helps." And then you kind of know what this person is up to. And they're looking for someone to talk to and lean on and not have to do anything to get better. And then what I said is, "Martha, I'd like to be your last therapist, and I've got the tools to bring you from severe depression to joy and happiness and intimacy and productivity. But sadly, the tools I use will not work without the homework. And so if you want to work with me, it's not a request, it's not negotiable. And believe me, I'm not trying to get rid of you. I hope you stick with me. But if you have any mixed feelings about doing the homework, this is not the clinic, not the clinic for you." Now, you're in luck. I've got a list of 20 therapists in the community here who also, like yourself, don't believe in homework, and you're free to go to any of them. But I'm hoping you'll stick with me. And that was similar to what you do, but even with more bite to it. And we gave that to 700 consecutive patients at my clinic in Philadelphia, and only 7 of them elected not to stay at the clinic because they didn't want to do homework. And the rest paradoxically increased their motivation. But yes, you're right about therapists resist because they're afraid of conflict. They're afraid to make patients accountable, and so they become codependent and feed the patient's resistance.
By the way, I wonder if the latter thing you mentioned is partially an explanation for poor results in studies, that the therapists in the studies don't emphasize the importance of homework and re-emphasize it and re-emphasize it.
Absolutely, and other forms of resistance too. And all of the outcome studies that the NIMH has sponsored, none of them has, for PTSD, for depression, for anxiety disorders, none of them has ever plugged in a module to assess motivation at the intake and to work through the patient's resistance to find out what the patient wants help with. They're all trying to sell something to someone. And when you try to sell something to someone, they automatically resist. That's why when you guys invited me on the show, I didn't, and including today, take it on myself to try to sell you the new developments that I've been working on, because then that would force you to resist me and fight me. And that's very narcissistic anyway. Why should I be trying to sell you or a patient anything? The selling is the cause of all therapeutic failure. But you're right. The therapist has to change before you can expect the patient to change. And therapist resistance is just as intense as the patient, sometimes even more so.
Tommy, did you want to chime in?
No, I was kind of lost in thought about the whole therapists don't like to be confrontational and fight, and then I just immediately go to where I work in the jail. And when it comes to resistance, I'm kind of a sledgehammer, more than a scalpel when it comes to my therapy. So I kind of just hit them with what I needed to hit them. Now, if you're not familiar with jails, there's a lot of personality disorders in the jail. So I hit, but then I get hit right back, not physically, fortunately, but so there is that kind of resistance there because I have to do a lot of quick one-off stuff. So sometimes I only have 20 minutes with an inmate. And so my form of resistance is pretty loud and a lot of conflict, but that's okay. They know it's a place where they can do that.
Well, I admire that, by the way, Tommy, and I'm a little the same way. That's why I use the empathy scale, so I have a net to support myself at the end, because if I'm too aggressive, then they can rip me to shreds at the end of the session, and then they know we'll discuss it the next time. But I'm also very, very confrontational, the same way you are. I'm very direct. I've tried to tone it down in my teaching because sometimes hurts the students' feelings. But I'm with you.
Yeah, I don't think they saw when you said hurt the students' feelings. I kind of went, nah.
Yeah, there's that too.
My aggression and my teaching style did not hurt the students' feeling. It's what they thought about my aggression and teaching style that's right. Hurt their feelings.
Yeah, they think you're criticizing themselves as if they have some self.
Yeah,
and they don't see it as feedback on a specific technique that they need to work on.
Maybe we have a difference about selling, because I feel that what I do in a way is selling. I try to sell them on doing their homework and the importance of doing their homework. And then I make a good case for that your emotions come from your thinking rather than situations. I try to sell them on that, etc.
Well, I've said before, I think you're very charming, and you were surprised at that. But I think that therapy is a matter of the skills of the people who are doing it as much or even more than the school of therapy that they belong to. And I experience you as a very gentle and warm and appealing and individual. And so I'm sure that your way of selling is very, very different and very, very effective for the majority of the people that you work with.
So you're referring to Tommy's way of selling, is that right?
I'm referring to both of you. Well, you're very different. You're very kind of charming and warm and open. And Tommy's you've got fire in your belly. And I love that about you, Tommy.
Well, thanks. It's the cop in me. I actually have that meta-analysis of CBT that you reference in some of your stuff, and reading it over. And for the viewers, that's the study David cited kind of at the beginning, that RABT, well, CBT specifically, didn't do much better than placebo. And this conversation we're having right now is kind of making me think perhaps there's some crappy CBT therapists that were a part of this within this meta-analysis, because you mentioned the skills of the therapist. And I'm not saying that arrogantly, because I've been pretty terrible RABT therapists from time to time. I've failed at that. So I was wondering if if the performance of the improvement of the clients wasn't due to some lack of skills on the therapist as well.
Yeah, I absolutely think that that's true.
Yeah.
Sure.
So anyway, I know that's kind of off the topic of paradoxical agenda setting, and have we kind of hit that topic hard enough? What do you guys
I
think?
think we just addressed the resistance, but
Yeah.
there are other aspects to it.
Well, there's a lot more to it. It's very difficult for therapists to learn. We've hit maybe the tiny tip of the iceberg. But the thing that you mentioned is perhaps enough for today. The whole issue of accountability and homework compliance. That's certainly an important aspect of resistance. Maybe we can go on to the fabulous article that you sent me that you wrote, Michael.
Thank you very much. And you're referring to an article called 5 Major Differences Between Our Abt and Cbt, which was popular on Psychology Today. Now, we just have about 10 more minutes left. So if maybe we can just take one point in that.
Well, one point that struck me was you were saying that the cognitive therapists don't deal with the underlying beliefs like the absolutist shoulds that Ellis so artfully took and acknowledged from Karen Horney, and he's probably the top anti-should person who's ever lived. And the other beliefs underneath, like I must be loved to feel happy and worthwhile, or I've got to be perfect to be happy and worthwhile, or I've got to be a great achiever. I absolutely have always been of the same point that you made there, that you can deal on the surface with the cognitive distortion so the person feels good in the here and now, but you also want to go down to the core beliefs and modify them so that the person will have a better prognosis for the future. And I agreed with everything that you were saying there. The only thing is, and I've never viewed myself as a cognitive therapist. I helped popularize and develop cognitive therapy, but I'm a human therapist, and I draw from many different sources, but I've always dealt with self-defeating beliefs. I've developed techniques to bring them out, the individual downward arrow, the interpersonal downward arrow, and I've developed dozens of methods for modifying self-defeating beliefs. I thought that all cognitive therapists dealt with these underlying beliefs.
Yeah.
But
So,
I think that's, again, something we'd have more in common than we would. I don't think we were on a different point of view there.
I think that in terms of the way you deal with it, you might be more philosophical than other cognitive behavior therapists who I've read. But what I was referring to was in terms of emphasizing a philosophy of life, and a specific philosophy of no demands, no musts and shoulds, no absolutistic thinking, just thinking in terms of preferences and advantages and disadvantages rather than world-ending scenarios. And I tell my clients, when they abolish all their demands, all their musts and shoulds, they're cured. I mean that somewhat humorously, but I'm trying to make that point that it's a new philosophy, a must-free, demand-free philosophy.
I go further than you. I love the word cured, and I think the reason mental health professionals hate it is because they're inept. I shouldn't say that. But when I was at Penn, we weren't even allowed to use the word recovery. And why can't we use the word recovery? My patients recover all the time. But I say there's 100% cured and 200% cured. 100% cured is when all of your symptoms vanish, and you go from depression or anxiety or whatever to a state of peace and joy. But the 200% is more of a spiritual dimension or a philosophical dimension of enlightenment, that, like what you're talking about, Michael. And I think that's very much inherent in our work. Now, my dad was a Lutheran minister, and one of the reasons I'm kind of anti-religious is because I didn't like what some of the hateful, I thought, messages that were, Jews were no good, gays were no good. As long as you were Lutheran, you were okay. And even Catholics were no good. And it just didn't seem religious. But I've gotten back to spiritual thinking in my elderly and semi-demented ways. And I feel like when you're doing really great therapy, even in the prison, Tommy, that it takes on a deeper dimension that you can call philosophy or spirituality. I'm still anti-religious, but yes, there's a deeper dimension to the whole thing that you're referring to, Michael, and that's what makes our work so incredibly fun and amazing.
Yeah, well, that's wonderful. And before we run out of time, David, I did want to ask you about another point of
Yeah.
probably agreement, but how we feel about most cognitive behavior therapists. And I consider myself very fortunate to be able to ask you this directly. And that is the point I made about self-esteem. It's my impression most therapists, even CBT therapists, try to show clients how to feel good about themselves, not only about their behaviors, which is great, but about their total selves. Whereas, as you know, in our ABT, we teach people there's a universe of difference between rating your behaviors, which is good and important, and then overgeneralizing to rating yourself. So the solution to self-esteem is unconditional self-acceptance rather than putting yourself up or down. But what's your view of that?
Yeah, and then once you've achieved unconditional self-acceptance, you can go up to the next level, which is conditional self-acceptance, or just throw the whole bag of shit out the window. Like Ellis taught us and the Buddha taught us 2,500 years ago, self-esteem is just a marketing term. Or as the Buddha said, there's no self-esteem at this time in California, and that's a damn good thing. The acceptance, you know, Ellis was really onto these things, as was the philosopher Ludwig Wittgenstein, but Wittgenstein didn't recognize the psychological aspect of his work. He was all into solving the problems of philosophy, but the thinking that you have a self that can be judged is just nonsensical. Trying to become worthwhile is not the goal of therapy. The goal of therapy is to throw the whole concept out the window, just as you say, and we're all pretty frail, we're all pretty flawed and screwed up, and accepting that and giving up this idea that you're going to be special or you're going to have self-esteem, that's where it's at. And I've learned a lot of that from cats. I used to be a dog person, and then when our beloved salty dog died of colon cancer after we moved to California, my wife converted me to a cat person, which I thought would never happen because I can't stand their narcissism because it threatens my own narcissism. But she taught me kind of how to get close to cats, and we adopt these feral, rejected animals that have had a terrible background and turn them into just loving friends. And for me, you know, the meaning of life is hanging out with one of our flawed kitties or cats that we've adopted and petting their belly, and they purr and they love me and I love them, and they're not show cats, they're just average cats, and I'm just an average elderly old fart. But it just doesn't get any better than that. Or hanging out with you two is really a beautiful thing. And if you open your eyes and appreciate what's happening to us, life is pretty amazing. And if you waste time trying to be special, you're missing out.
Well, you know, I know a pretty depressed cat, and I'm happy to learn I can send him to you. Tommy, we have another minute or two. Did you want to say something in conclusion?
I don't try to be special. I just am. That's all I got today.
Okay,
I agree.
Very good. Yes. Well, once again, thank you for spending these 3 videos with us, Dr. Burns. It's been a wonderful discussion, and I've learned a number of things, and I'm very happy to hear you're pretty much on board with Albert Ellis and Our Abt, which I knew you were on board with Albert Ellis before, but I wasn't sure how close to Our Abt. It sounds like that's pretty close. So
yeah, I've always thought he was a giant, and I've always really loved and appreciated him, and it was been a great honor and a lot of fun hanging out with you guys. I'll never forget it.
Yeah, I appreciate all your time here. Okay, well, thank you for watching, and we'll be back again in another week with another podcast. And if you like this podcast, give us a thumbs up, and we'll send 1/3 of the thumb to David Burns for that. And
thank you.
We'll see you next week. Bye now.